Thank you all for coming and joining us. So our panel today is meant to be conversational, and we're really going to focus on this rapid evolution of AI. And there's some well-known challenges, and there's some new emerging challenges. And so we're going to discuss those. And our panel here each have different perspectives to bring to this, and I'm going to sit over here and join them in this conversation. So I'm Erica Schorr. I am an associate professor in the School of Nursing at the University of Minnesota. And I will let each of our panelists introduce themselves, and then we will get the conversation started.
Hi, thanks for having me, the cleanup crew. So my name is Uday Kumar. I'm a cardiologist in cardiac EP. I teach in the Stanford Biodesign program at Stanford, but primarily been an entrepreneur. I run a company called Element Science. It's a wearable patch-based defibrillator. And previously I founded a company called iRhythm, which makes the Zio patch. And so I've been involved in wearables and AI/ML for quite some time. So happy to be here.
Hi, I'm Vimal Ramjee. I'm a non-invasive cardiologist at Memorial Hospital in Chattanooga, Tennessee, which is part of a large enterprise called Common Spirit Health System. And I direct the cardiovascular CT program there. I'm the past national co-chair for cardiology and innovation for the enterprise and guest faculty at the Harvard Health Systems Innovation Lab. Glad to be here.
And I'm Viet Le. I'm a preventive cardiology PA and associate professor of research at Intermountain Health. I happen to do research with the Cardia Alive Core team and hopefully providing more of the research, but also clinical perspective.
There we go. Okay. Thank you all for joining me today. So let's start with, how are we currently using data to improve patient outcomes from each of your different perspectives and roles that you have?
Sure. I think having been in this area for quite some time, I think a lot of the places where we use data are places where we have sensors to collect data. So whether it's ECG, whether it's radiology images, those are primarily the places where computers can probably do things better than we can as humans. So in the early evolution, that would be the place. And now it's shifted to other sources of data in kind of more of the back office, customer service, other things that we can talk about. But in my area, it's really large volumes of sense data in which the variability with enough samples can basically be known.
I would say from my perspective, imaging really is kind of the meat of where I interface with data. It's an exciting time in cardiovascular imaging with multimodal data in terms of echo, CT, MRI, that is now providing extraordinary and differentiated insights in terms of individual risks and conditions that we did not necessarily have before. And so we've been, successfully using a number of different tools that perhaps we'll get into, but in the imaging lab to just lean on that data and to use it to provide high quality care for our patients.
So at Intermountain, as a researcher, we do a lot of data query, a lot of electronic or enterprise data warehouse data analytics. And from my perspective, it's so nice to have, especially at Intermountain, where people kind of live and, yeah, they die too, but they don't move often. And so we have birth to death records and large families. And so the genetics is fascinating, but to be able to have pre-disease data leading into later disease data is great. Then, of course, I'm a clinical trialist, and so we do a lot of prospective trials, one of which has been able to work on whether or not we can identify acute coronary syndrome with, a handheld portable ECG. And so that's fun. The one thing that I'll say with imaging is I'm also a cardiac PET CT coronary calcium guy, and we do a lot of data analysis in that space. I am very, very excited about how AI will help us to identify things outside of the cardiovascular space, but augment how we pick up diseases like hepatic steatosis, et cetera, that we're not looking at in our own siloed areas.
So I'll start by directing this question to Uday about element science, but I think that all of you have a different perspective. So these AI models are constantly changing and evolving, and when you're looking at this regulatory landscape, how do you manage that? How do you stay at the top and make sure that this is constantly changing and the regulations have to be somewhat static? Can you speak to that?
Yeah, I think it's a journey that FDA is on in real time. So I think a lot of the regulations that have started to come about are a function of FDA trying to catch up because the technology and the companies are moving fast. So I do think from our perspective, it's no different than anything else. Like, what are the things that FDA cares about, safety, effectiveness, et cetera, and then how are you going to show that to them in a way that's maybe understandable in terms of how they looked at things before. So I'll give an example. So in our defibrillator, we have a machine learning model. It's not in real-time learning, but it's developed in a certain way. And so we spent a lot of time with FDA getting them to understand that it's not a black box, meaning there's nothing happening, once the patient's wearing the product, it's not making decisions that are different than what we've already tested and validated against. And so it's really trying to think about their version of regulation is you build something, you do verification and validation to different standards, you submit it, they ask questions, they think it's, and they'll say, okay, it's now approved or cleared depending on the type of product. That's it, and then you do it again. And so the speed of which those things are changing, and so for instance, the PCC approach, which is the predetermined change control, so you can now say to FDA, here's what we're going to do with an algorithm over the next year or 2 years, here's the type of things we will change, and if they approve that plan, now you can just go do it. So all of these things are kind of in flight, and so it's kind of making sure you're working in partnership with them. It's not like they have the answers, and they still have a mandate of making sure they're not going to release something that's not safe. So sometimes it's a bit, you want to go faster, but there is a pathway, but they're definitely collaborative.
I might add just a little bit. I think Uday articulated it really well as far as we're all just trying to learn, and I think that's kind of where we are. But from a clinical practice standpoint, probably less in the regulatory side for FDA, but still governance related. I think a pattern and that I've observed is that there's a lot of effort and attention to the pre-deployment vetting of clinical AI solutions that we bring into systems and healthcare facilities, but yet not enough attention during the implementation and post-deployment phase, which are critical to be able to use these tools responsibly and ethically and to yield the true ROI that you're promised during that first meeting when you meet with that vendor. You're going to capture X percent more, people with this condition, or you're going to reduce your turnaround time for X test. I think that putting more effort into, from a clinician standpoint, benchmarking how the particular solution is working, looking at simple things like the diagnostic accuracy, the sensitivity, specificity, and putting that effort in intentionally is something that I do see as a major gap clinically. And I think a large theme there is just being accountable to the solutions that we bring into the health system is something that is definitely not where it needs to be. And so I think just a parallel, with the FDA, I think we are learning too on the healthcare side how to properly and responsibly use these tools. Yeah.
I'm actually kind of curious because the implementation side is one part, and there's this kind of this set and forget where administrators, we do all the things, the cybersecurity brings it in, etc. But then from an administrative standpoint, they're like, okay, it's good, it's right, it does all the things, right? And so I guess on the one hand is how much do you educate when you're trying to go into a system, and how much are you working on? Because from our standpoint, I've tried to bring a couple of different AI systems in, and it's so tough on the cybersecurity end. But then on the end, they're like, okay, well, once we get it in, it's just done, right? And they don't recognize an iterative process, but how do we educate, whether it's FDA? I look at my admin as almost like another FDA that's approving things, but they don't understand AI, and they don't understand how all that works after that. It's an iterative process. So I guess I've said I've been the questioner, but those are my thoughts and or my questions in that space. And from a research perspective, we haven't implemented a lot of AI into. I mean, we're still paper, and we have, big charts and stuff that we're still putting CRFs and ECRFs. We haven't utilized AI a lot in that space, and I think folks are worried about what happens. Does it stay in the space internally? Does it move somewhere? Does it go up in the cloud? And then that's where the regulatory issues come from on our part.
I think there are two things here. So on the infrastructure and where the HIPAA and the PHI and all that stuff, yes, there's still more to be done. I think I would just change the conversation a little bit, and I think it's really important, and we spend a lot of time at Stanford Biodesign really thinking about what is the unmet need we're solving, because I think particularly with AI solutions and software solutions, a lot of end up being diagnostic or pieces of information. They're not therapeutic. So if you look at the value proposition for a lot of these tools, it's an economic one oftentimes, assuming clinical is a net equal. So that's where a lot of the companies really don't follow the patient and the full value chain to understand, if I get this piece of information at this point in time, do I have any lead time or lag time bias, meaning that I would have known in 1 hour anyway, so am I just adding costs? Or if I know this, does it really change the natural history of what will happen in terms of an outcome that a payer or the healthcare system cares about? Because when you do that, most of these tools are not necessarily changing that, and they're just adding cost. And so, for instance, we spend a lot of time teaching our fellows how to do deep Markov modeling to understand all of the pros and cons of different pathways at Stanford, to understand whether at the end of the day, will the pathway have a high enough pretest probability of having an impact? And the other thing I'll say is, it's really thinking about segmenting populations to make sure that the population you're going to deploy something to is high enough risk or high enough, will get enough value. The example I'll give is, since I founded iRhythm, when Apple Watch came out, our stock went down because people thought people just. The next day it went way back up because people realized that as a screening tool in a lower pretest probability population of people just wearing Apple Watches, you're going to find a lot of false positives and a lot of stuff, and now you need to get a clinical test. So maybe the take home is that without understanding the full economic and clinical utility of something from end to end and the cost that gets there, there's a lot of money being spent on things which may not go anywhere because ultimately payers are going to realize it.
Yeah, and I might just add one quick thing. I think you made some great points. I think a lot of these projects are being treated as technical rollouts, and that's a real issue. And so if there's one thing to take away, it's involve your clinician leaders earlier. They really need to be part of that process, working very closely with the technical teams, because there are so many nuances that the third-party vendors and industry perhaps doesn't really understand on the patient journey that we are dealing with every day. And dozens and dozens of times I've edited that, and when we bring a new technology in, even against the advice of the vendor, because they have a certain perception or perhaps a limited understanding of what we're doing on the clinical side. And so it really needs to be a collaborative process, but my experience has been that there's a large percent that are treated as technical projects. It's of course a heavy lift from an informatics standpoint for the IT teams, and that sort of tends to be a magnet of attention, and then there's sort of this paucity of attention afterwards once it's rolled out. And yet that's the most sacred thing we do, is take care of the patient. We need to actually spend a lot of attention there to really see that value. And so I've seen several AI algorithms that have been rolled out without that attention and actually cause harm, which is unfortunate, tragic, and frustrating. And so I think involving clinicians sooner is definitely important as part of that. And I think what Uday said was also something that reminds me, as far as the algorithms, one thing that I feel that is not highlighted enough is getting FDA approval and or payer coverage is often conflated with something that is clinically beneficial. And we really need to tease those apart. When you get FDA approval or payer approval, that is a starting point. And you really have to put the effort in to understand in your population, in your teams, in your facility, with your patients for your problem that you've thought about, is this really going to be something that's beneficial? And I think when you do that due diligence, you'll find, I know that we've found that using less is often more. And I think that's a big part of our strategy, being selective for problems that we feel are true and have heavy weight to them.
So I think that's a perfect segue into, we have a model where it's treatment-focused disease, and a lot of these commercial devices are aimed at in the wellness space and people detecting something that's really focused more on primary prevention, which the money isn't there to support those tools. What are some strategies? What kind of evidence? What really needs to be in place for those tools to be helpful? Because I know that clinicians are getting patients who are coming into the office and they're showing them loads of data. What do we do with that? Do you need to now make a clinical decision based on that? These devices aren't FDA regulated, yet there is a place for them, and we know that they are almost ubiquitous now.
Yeah, I think it's also a generational change in terms of how people consume information and interact with and believe information, whether I think maybe Gen X and before were maybe more skeptical, and I think there's less skepticism now for whatever reason. But the the cart's out of the barn, it's gone. So people are going to bring information. I think the challenge for physicians is liability and trying to do, what do I do with this? And that's what I said before. People show up with Apple Watch tracings all the time to doctors like, what do I do? Now I have to order a Zio. And as someone who says that's not really a good reason, because you might, it's probably a false positive. It might be real, and there are definitely anecdotes. So I don't know. The only way I could say, particularly if this is consumers paying for that themselves, that's a hard one to say, you can't do that. It's different if we want to get payers to pay for preventive type of information. Then it's the same bar, like clinical value, health economic utility, to really show that getting this information does something that changes the clinical and economic pathway of that patient.
So, I mean, coming from coming from a preventive cardiology space where folks are coming in all the time with their wellness information, you're right. I mean, the horse is out of the barn. It's so far ahead, and we're trying to catch up to it. Like, wait, come back. I don't know what that sleep number means, and I'm not quite sure that we don't know what to do with the pulse ox that's doing all the things, although, boy, it looks like we need a sleep study, So who's on the hook for that? Is it the wellness company that needs to now come back and go, well, we just gave it to them when we're making money off of this, but those patients are coming into us on the medical side when we haven't vetted that, we haven't validated, we don't have any outcomes based on those. So which side is it? And should I, as a researcher, go, well, I guess I'll partner with someone and say, let's just do an investigator-initiated study, and we'll, since you're patched into Intermountain, I've got at least this side of the data, and you're accruing all the tons and hundreds of thousands, hundreds or a million data points. Where?
Yeah, I mean, I might just say a few things. I think, a lot of these wearables and direct-to-consumer preventative solutions are predicated on AHA's Life Essential 8, right? Yeah. I mean, and it's wonderful. I think there's tremendous opportunity if they can make an impact earlier and prevent people from needing us. I think that's a win. And so I think that's the objective. There's work to be done, and I think certainly generating more of that clinical evidence, a finding is not necessarily clinically meaningful, right? What's 10 seconds of AFib on a wearable? I don't think anyone would tell you that's meaningful who's a clinician. And so I think there are a lot of questions that yet to have to be answered, but I will say that a couple things. One, having all of this information I've observed in the clinician side is creating a significant amount of anxiety and overwhelm. I have people coming in thinking they're going to drop dead. My HRV just went down. I Googled it, and Google said, I'm done. Am I going to die, Dr. Ramjee? No, literally. I answer this like once a week. And so a lot of what I do now is provide therapy and reassurance to them. And so I do think that there's a shared responsibility that these innovative companies need to bring to the table some way to understand for people to understand what they're seeing, and to have more nuance about that. Not that they're not doing that, but I think there's a lot of work that still needs to be done there, just based on the signals I'm seeing in clinic. The other part of it is, I had the privilege of sitting in on the Southeast Region Board meeting yesterday afternoon, and they had a wonderfully talented panel of physicians and scientists. And one great question that came up is, we put hundreds and thousands of hours collectively as an organization in putting together these incredible guidelines like Life's Essential 8 and other things. How do we distribute that to populations that will benefit, or at a broader scale? I think now's an opportune time for us to think about working closely with these innovative companies to bring AHA science to these people, so they're not going to Google or to some LLM and asking it, am I going to be okay? And so I think there's an opportunity to provide some guidance to consumers on that front. And I would love to finally see that the cost come down, because the groups that are most vulnerable, who need these things, like guidance on what to eat or how to sleep better or how to exercise a bit more, are often the ones who are not able to afford these tools because they don't have the financial means to do that. They need their $300 to pay for food for them and their family for the next 4 weeks. And so they can't buy an Oura Ring or an Apple Watch or whatever it is. And so I think that's something to be thoughtful about as well.
I would say, though, I think the challenge for a lot of these consumer companies or aiming in the directly to patients is the fact that they don't want to narrow their market. Because if you sell to everybody, you're selling to a lot of people who are just worried, but they don't actually have something. If you look at studies of Fitbit, first 6 months people use it, then it's in the drawer. Because the idea that some of these tools will help the unwell get well really turned out to be the fit getting fitter. So the people who are really competitive about that, it wasn't the people who, at some point, if you have as a cardiologist, I boiled things down to, if the advice is stop smoking, if it doesn't impact the 3 things of stop smoking, move more, and eat in moderation, which are the big ones and the hard ones, the other ones are kind of on the margin sometimes. And so sometimes we believe the technology is going to, and so for some people it will motivate people, but that's usually it's payment, like, if you paid people, maybe they'll do something. It's having a child. Now I'm living for something. There's different things that motivate people to do things. So I think the challenge for a lot of the consumer direct companies is that if you actually start narrowing your pretest probability of patients who will benefit from that, it will limit your market. And that is not something that any of the companies want to do. They want to have the biggest market as possible, which is why they don't typically go down a regulated path.
Yeah, I'm glad you brought that up. There are complex psychological factors that impact behavior change, and so it's more than what we realize. And I was going to bring up the example of heart rate variability, because that is one measure in particular that there's so many things that impact it, that even for clinicians to isolate changes in heart rate variability and what's causing them is very challenging. And so for a layperson to do that is nearly impossible. So before we were talking about deploying these tools, you brought up some points about bringing clinician leaders in earlier in the process. Oftentimes what's happening now is people are making these decisions at a larger scale in a facility. They're being implemented, and then the clinicians are just part of it, right? There's little to no training that happens. There are algorithms that are coming at clinicians, alerts, right? We know from early days of EHR, alert fatigue. And I'm wondering your thoughts on a similar challenge, yet slightly different, and where there are algorithms and models for each facet of care, right? So a clinician could have a model that's giving them a risk stratification for a patient, maybe is guiding the pharmacological focus. And so now, instead of just using their clinical knowledge to make decisions, they're trying to figure out all these different tools and integrating that in. How is that changing what it's like to be in clinical practice? And are we thinking about how we can prepare future clinicians to provide care in this new, complicated environment?
Look, it takes like 17 years to implement a guideline.
But these things are happening so fast, right? So this is very different. It's a different landscape.
Yeah, it's a different landscape, and I don't know that BPAs are the way. And it's like, and I'm not going to shout fire, but if you shout fire in a room, you cause panic. And that's what BPAs are like. They're just like, hey, there's something wrong.
Yes.
But what's better is if you say, okay, I'm notifying you of this, but these are the actual care process models you can click on and move towards. Whether you know it now, in fact, it'll give you a little blurb, information on why we've chosen this, but you have care process teams that should be able to build those things based on data that's coming in. And it doesn't have to be on the individual clinician's head necessarily, but if we have teams that are thinking through this process and then implementing it. But you're right, I mean, we're no different at Intermountain, but I imagine all health systems have that one supply chain person that's bringing in things that probably aren't appropriate and haven't been, communicated well. They haven't been communicated well, and suddenly you're a pawn to having to do these things that you don't know how to use. So I think we just need to come back a little bit and say, that's fine that you have an in with someone, but how about you always bring in a clinician leader, or at least have a clinical team in that area that can ad hoc come together and talk about whether or not this is an appropriate technology in the space and how would it impact the care process at that facility, in that community. Because not all will be appropriate for those communities, or even with the flow that is, of the care that is delivered at the facility.
Yeah, this is a good question, Eric. I mean, this is a big problem. There's system overwhelm with the number of AI solutions that are encroaching healthcare facilities and the large systems, and so I think this has been a topic of great discussion. I would say on a clinical side, less is more. And that's a principle that I stick by and that I think we've had a pretty good experience with. Having a principled approach where you really have to intentionally think with your clinicians about, well, what are the problems that really require us to look at this type of AI algorithm for a solution? Or do we even need it? We have a number of different innovation programs, and one example, I created an aortic aneurysm registry about 6 or 7 years ago at our facility, just with a whole bunch of clinical operation and workflow streamlining. It was very much a manual, low-tech innovation project. It is now one of the biggest registries in the country. There's no technology there, but I am certain if I was enamored with AI, then I would have been able to find a company or 10 to help me with building this and detecting and surveillancing. Yet I didn't really find that that was necessary. And so I think our sophistication about how we approach decision making on what we use is not quite mature yet. I think there's a lot of excitement naturally about these solutions, but I think having some caution and care about what we're using is going to be critical. I have generally seen that, at least in our system, there's intentional direction to unify data architecture and the EHR to position for multimodal data processing and to be in a advantageous place when when you have all that data in one sandbox, then you can potentially really leverage that to generate clinical benefit in the coming years. I think that's something that I would anticipate. But using many models is definitely not a good strategy. Yeah.
Maybe I can make an analogy here. So as an EP or cardiologist, when we look at a single lead to look for rhythm differences, I understand when I see an irregular rhythm what that means. I understand what that means in terms of what a P wave means relative to how the heart contracts or the atrium is depolarizing. The challenge with some of these models, and it's going to come up with a lot of the ECG AI models, is are you going to make a decision based on that when you're not sure why this is calling something? There's hypertrophic cardiomyopathy somewhere in here, but there's a black box that determined this. So what are you going to do? Are you going to order an echo now? And so to confirm it, and so there is this potential increasing cost paradigm and harm potential for additional testing that could happen because we don't understand what something means, even though over time it could be pretty much right all the time. Mm-hmm. But that's a big leap in where we are, where physicians now are going to be having to trust decisions where they don't understand why, and they're just going to have to trust it. And that's where I think it's going to be very important. And payers may be the ones that might shut this down a little bit, because they're like, well, we're not going to pay for this in terms of the next step and the next step and the next step. And so I do think it's more incumbent now on the industry, both folks who are not going down regulated path as well as regulated paths, to actually start to show why something happens, either mechanistically or provide a reasoning such that if I as a physician get a piece of information and I'm supposed to act on it, I actually know why I'm acting on it, not just because the model told me. That's where we're going to have a lot of, I think, companies spending a lot of money but then not being able to get to the next level, because doctors are like, I don't know what to do, and I'm just now adding cost, and the patient's like, wait, now I got a copay for this other test too?
Yeah.
So there's just it's like can unwind very quickly.
Yes, that's exactly what I was hinting at, Uday. And so, yeah, you were providing examples where there is a strong rationale that's provided to the clinician, and I think that's different versus some of these tools. We do know that they have diagnostic value, and there isn't a clear rationale for why. We know that it works, it's accurate, and I think that as clinicians, that's a bigger struggle, because if you're teaching someone to think critically and they have good practice, they should, to just do something because the machine told me to do it, right? This is a dangerous path. And so yesterday there was this Stump the Provider, this game that they played with the clinicians versus AI. And as you would suspect, sometimes the AI was right, sometimes the clinician was right, sometimes they were both right, and sometimes they were both wrong. And so I think that this is just going to really challenge how we're educating clinicians to think critically, and what does that workspace look like, because it's very different than it was when you were all in med school.
And I would say that moving away from the justification by anecdote, meaning like, oh, there was this one time that I saved a patient, great, but what about the 1,000 times when nothing happened and we spent the money for it? So, because it's kind of a no-win situation for physicians, because if you don't act on something and something happens, and then if you act on something and it leads to something else, that's why I think it's really incumbent for physicians and industry to get ahead in a regulatory, or like set some standards, like what do we really need to show in what population, even if we don't understand it, but at least we understand the outcomes we're going for, the parameters of who benefits and who doesn't benefit. Because otherwise, there's the real opportunity for harm.
Yeah, and that's a perfect segue into my next question for all of you. As we know that there are disparities that exist, and one of the main criticisms is that these models are being trained on really homogeneous data sets, and so then when they are applied in a more diverse population, we're actually just further exacerbating those existing disparities. So what types of strategies? What are your thoughts on this? We know it's a problem. We know human bias is a problem also. And so now you think about the two of those in combination, it seems quite problematic.
I think, well, these guys may know more than me on this front, but at least from my basic standpoint as a clinician, when I am vetting an AI solution, looking at the algorithm with some, granularity really helps. And I think that gets into having what might be a little bit of an uncomfortable conversation with the vendor. How did you train your data? What are your training data look like? Do you have that published? Mm-hmm. That's a starting place. As an example, we were just vetting an Echo AI solution. There are several that analyze the images of a heart ultrasound to be able to either measure pertinent structures and put that into a reporting template, and even perhaps predict the probability of specific conditions based on the guidelines. And so this particular organization had trained their data on largely Asian, East and South Asian data pools. That was not representative of my patients in Tennessee. And so the next question was, well, have you validated it in other demographics? And they had some wonderful data that spoke to that. And so that was reassuring to me. That's a starting place yet again. And so I think one thing that I would say, as far as just looping back to what the previous point was, because this is very much connected, is there's this process that's called automation complacency that occurs for clinicians. In use of these models, you get 8 right, it finds a nodule 8 times, you build trust. It's human nature. And then we just start to become complacent about that, as opposed to really critically thinking about every single output every single time and saying, well, is that right? Do I need to look at that again? And questioning that output. And so I think pushing against automation complacency has been one thing that's helpful for our team. The other thing is really being structured about performance metrics helps us understand if an algorithm is performing or underperforming in specific demographics. And so as an example, we're using a deep learning enabled CT algorithm in our program to detect obstructive coronary disease. And it's been so helpful for me to look at those metrics, because when I change something as small as the beta blocker pre-dosing for their coronary CT scan, gosh, the model does not perform the same. And that's really vital information as the person directing that program to be able to make appropriate changes back or adjust accordingly. But I can tell you that the large majority of programs don't have the resources and or time that are intentionally dedicated to doing this. And so it's a challenge. It really is.
I think to the question of bias, so actually when we interview fellows for our Stanford program, we have a whole room that I run on ethics and principle decision. And one of our scenarios we give them is to work through this. What do you do in terms of if your data set has bias? Do you deploy it? Do you wait? And there's no right answer, and I do think one of the things with data sets that sometimes it's obvious, like Google's famous faux pas, where they had a facial recognition software and then realized after the fact they may not have had enough represented races in their data set. But I do think it's also thrown around as like, well, what demographic do you care about that matters for the thing you're looking at? And so really being specific, because you could go ad nauseum, like I didn't have enough of that demographic or that population, and at some point, if you keep waiting and waiting, you're not actually giving benefit to those who are in there. So I do think we have to be very specific when thinking about data sets and bias. Why do you think something is biased? Because if it's something that has to do with something that's universal across all people, maybe that's okay. And so I think we have to get to a place where there's a little bit more of a nuanced discussion versus just saying, well, the data set's not representative, but why and how, in what way? The challenge is in the future when we don't, from the last question, when we're not even understanding why a model is, you don't even understand what the bias could be.
Yeah, I appreciate that perspective, right? So thinking about holding off on deployment where there's a benefit for maybe even if it's a small number, and then you can learn and then revise over time. But yeah, we do reach this sort of kind of analysis paralysis where if you're holding back until you've proven that the model is perfect.
But then it's really important to be specific and thinking about, like, so let's say you roll out something in your hospital system, this is the scenario actually, where it benefits certain people. How do you message for other groups? Let's say you have two patients in a room, one gets it and one doesn't. How are you going to talk about that? Are you just going to withhold it from this person because you haven't tested in that person? Or do you explain, like, we don't have data in you, but we're going to do a study to understand, would you participate? So there's a lot more nuance there, but I do think we want to make sure that we're not withholding, but also not moving too fast.
These are all great points, and I think to be fair to AI and implementation, as a clinical researcher or sponsored clinical trials, we don't enroll enough women. We don't enroll enough ethnicity, but we have them in the guidelines to use this or that on everybody. We generalize it. And so I think that there's always going to be some type of gray in that. Hopefully we continue to fix this, enrolling more women and more ethnic groups. But I love that. I mean, the enemy of good is trying, of doing anything is trying to go to perfection. So the other thing that I guess I hadn't really thought through the complacency part of things. But it's not just AI. When we trust anything, like you said, it's human behavior. And we do things in medicine already that follow that, regardless of whether it's AI or not. I mean, you trust the X-ray, you trust the CT scan, you trust the CAT. And we do a lot of things on labs when there's an error rate in what happens at the lab. What if it's someone else's lab values and you start doing things? So I do think that we have to just be transparent and have these conversations out loud. But folks have a tendency to say, well, it's AI, so it's better, it's perfect. I don't know what it is about saying the word AI, but people light up and it's like, it does all the things. No, it does not.
That's how you get funded. You just have to say AI.
That's how he's getting funded. It does all the things.
all of the things. So as we wrap up here, just curious to hear from each of your perspectives. What is the single most important thing we could do, either from a clinical standpoint, a regulatory standpoint, over the next year to ensure that AI in cardiology benefits everyone, or at least aiming towards that?
I mean, in my mind, let's not forget the patient. They really should have a say in some of this, like nothing about me without me. So as we start doing these things, and there's a regulatory thing that they don't understand, there's how we implement it that they don't understand, but let's help them understand that so that we can have better conversations. Just, as we said, don't implement things without clinical thought processes, but we should be asking patients. So I think as we move forward, just to remember that, because they're coming with their own devices. And so they obviously have a different thought process than we do if they're choosing things that are direct to consumer that we haven't studied.
Yeah, I think that the patient-centered approach is definitely something I think is critically important. Part of that one thing that I see as the key action and differentiator to really do a better job on that front is earlier and closer involvement of clinicians in bringing these technologies to healthcare, because clinicians are there at the bedside. They are the ones who are administering care. They are the humans in the loop often for these algorithms. They are the ones who are carrying the plan forward. And I think that that's a critical missing gap that has a lot of opportunity for improvement.
Yeah, I would just say that the way I would think about AI or anything is just another tool in the series of many tools that will be invented before this and after that. And so I would say put aside the AI and put it in a toolbox. We just have more and more tools to solve problems. So I would say that physicians and people in the healthcare system should really think about what do you want to do better? Like, ask the question. If you're sitting there like, I wish I could, okay, focus on that. Because if you don't articulate the need you have, someone's going to come with a solution that will be bolted onto your problem, and it won't get you the results you want. It maybe help a little bit or not, and you won't have control of it. So I think the biggest thing, AHA, societies, physicians in positions of influence, what are the high priority problems that we want to solve for our patients as a whole, and then put that to the industry. It's like, these are the things we think are most relevant today. Otherwise, you're going to have people coming up with all sorts of tools which may have incremental value and not really solve the biggest things. And again, those may not actually have to do with anything with AI. They may have to do with getting people to have enough money to eat. So I would just say articulate the problem based on what you're seeing in your practice with your patients, then go find the right tool for it.
So intentionality with AI, involving the patient and clinicians early on. I want to thank everyone on my panel today for joining us, and thank you all. This wraps up our discussion.
Thank you.